I don't know the last time we saw each other, but also Patrick and Elizabeth. And I'm really happy that we can connect now from anywhere, through different time zones, that we can connect and have a meeting from, you know, our living rooms, offices, which is really nice. So I won't say much, but really looking forward to hearing the good things from you guys.
Thank you.
Thank you.
Thank you very much.
Thank you.
And I just want to confirm that we are now live on YouTube as well. And in 1 minute, I will let in everybody else. So do you guys have any questions before we do that?
I think from my side, no. Thanks so much for the invitation, and congratulations to you and Masanja and the whole Ifakara team. This is a wonderful initiative, and one we applaud, and we would like to support in whichever way we can. So just a big thanks. A second question: how are you going to run this? Give us a little bit of a guidance here.
Yeah, so a good question. So it's a Q&A essentially.
Yeah.
We have done a review of the subjects that we wanted to capture today.
Yeah.
So Sheila and myself will be asking you guys questions one at a time. And for each question, we have a slide, an illustrative slide that we will use to anchor the discussion. There is a lot of people online. They are free to send questions or additional questions by chat. And some of these questions, we will bring them forth for you to address immediately. Some of them will be addressed by the other experts on the call, and the whole thing is recorded. So it's really just a conversation, but it focuses a lot on technical detail. Sometime we will ask some personal questions, but it's mostly on technical detail. So it's really, so the audience includes the researchers, students, NMCP officials, advocates, and many, many other people.
So I just want to say, I'm sorry, I will have to probably leave 1 hour into the call. It's a bit unfortunate scheduling, and it was out of my control, but I'll tell you, there's an important meeting with NIH and NIID folks and senior leadership taking place at 4, which was not the plan at all, on RTSS, something that is very, very close also to the heart of Ifakara. And depending on how things go, I may have to be there at least for the introduction and then rejoin or not. But sorry about that. It was totally out of my control.
This is perfectly fine. And we will do what we can in the first 1 hour, but hopefully you can join us after the engagement. So thank you very much. I'm going to bring in everybody else, okay?
Yeah, we can proceed.
Oh, thanks. Elizabeth, you're in Brazzaville, right? Are you in Nairobi?
No, Harare.
Oh, yeah. Good morning, everybody. Welcome to our 20th edition of the Ifakara Masterclasses. As you can see, again, we have a great number of people joining us today. Welcome to this, and kindly mute your videos and your microphones upon joining. We will be starting in approximately 1 minute. So Patrick, Pedro, Elizabeth, as you can see, there's just about 180 people already joined. We will We are expecting many more, but I think we're just going to start anyway. Shell, are you there?
I'm here. Thanks, Fred.
Brilliant. So I think we are all go actually. So we could let in the last batch of people and then we can start. Patrick, where are you joining from?
I'm in New York. I'm in the office. I don't know if it's too bright, if you can see the bridge behind.
So that's 8 a.m. So that's good for you. That's all right.
It's good for me.
That's cool. All right, I believe we can start now. Thank you very much. Can you just confirm to our speakers today, Professor Pedro, Alonso, Dr. Elizabeth Juma, and Patrick Kachur, can you confirm that you can hear me?
Yes, loud and clear.
Fantastic. So I guess that gives us a good starting point.
Yes, I can.
Thank you so much, Elizabeth. Thank you so much, Patrick. And to all our colleagues joining on the call, as I said earlier, we're very happy that you can join us again today. Even more happy that we can be joined by Pedro, Elizabeth, and Patrick. Today, we will be having a great new discussion on a wide range of subjects around malaria. We have distilled a number of key questions that we will be discussing with our experts today, focusing on the gaps that we have currently in malaria control, where we really want to go, and what we must do to get there faster and with as few deaths as possible. To begin with, 1,000 lives a day. This is the number of lives that we lose approximately in Africa every day. And I would like to actually begin by asking Elizabeth very, very briefly to talk to us about why the number 1,000 lives lost, as big as it is not so much talked about in the international community. Is this a sign that malaria is still a neglected disease?
Thank you, Fred Ross, and thank you, colleagues, joining on this call from all over the world. 1,000 deaths per day, it's a little over that, yes, particularly in the African region in sub-Saharan Africa, given that we account for about 384,000 deaths occurred in 2019 alone. So why isn't it shocking? I think we don't speak about it enough, and the spaces are taken over by a lot of other things, but it has actually, in my view, even though 1,000 a day is very shocking, it was worse. We had the every 45-second death that was happening in the past, and that was equally shocking. It has improved a little from that, not by much, but it has definitely improved. We have made several gains on malaria mortality in sub-Saharan Africa. And, but we still need to talk. The deaths are still not acceptable, given that nearly 85% of these deaths occur in children, in young children under 5. So we still need that advocacy to keep malaria high on the agenda and stop these entirely preventable deaths. They are entirely preventable. Is malaria still a neglected disease? Yes and no. Yes, but yes, because we need to identify populations that are still not reached with our essential interventions. There are still parts of our populations, especially in sub-Saharan Africa, that are not accessing these interventions. Some of them are special groups, others are the usual vulnerable groups we know, but until we reach them, for them, malaria still remains a very, very real threat to their well-being and life. So for them, malaria is neglected. It may not be neglected because a lot of advocacy in the last 2 decades has done. Financing has significantly improved, even though that is going down. Interventions have been scaled up to reach a vast majority of the population at risk, but we still haven't reached everyone at risk. Thank you. Fredros, you're on mute.
Yeah. Thank you so much, Elizabeth, for that reminder. Before we proceed, I would like to go very briefly to Pedro, just so we can have a general overview of the key messages from the last World Malaria Report, the World Malaria Report 2020. Pedro, you've served us very well. Congratulations for the great job you guys are doing. We understand that this is a tough battle. We understand that the conditions, financing, the disease itself, its biology is not as easy as people might expect. In your opinion, what are the key messages that we must take away from the 2020 World Malaria Report?
Right. Well, thanks, Pedros. This is a special World Malaria Report because the key function of this annual document that WHO puts out is track progress in the fight against malaria. It started, I believe, in 2005 with what was at that time an African malaria report, it by and large has been a vehicle to show the great progress that had taken place over the first years of this century, and until I believe it was in 2017 or 2018 that we realized that we were not making any further progress, and started ringing the alarm bells because we had just got used to every year the report was better than the previous year, and that was an uncomfortable place to be in. And with my colleague and brother in this, Abdisalan Noor, we all recall it was not an easy one because the community didn't want to hear bad news. Anyway, we've also been using the World Malaria Report to highlight perhaps neglected subjects. So also a couple of years ago, 3 years ago, we highlighted, for example, the whole issue of anemia, a very forgotten subject in malaria, which since the advent of RDTs, malaria is a parasite plus fever, while probably the most important cause of malaria deaths, malaria-related deaths, is anemia. So we've used the World Malaria Report to highlight areas that we thought were partly neglected or where a special attention was warranted. Now, the 2020 World Malaria Report is a special one, among other things, because it basically looks back at the last 20 years. And there's a first chapter, which I think is, sorry to say this, and I don't take credit because it's Noor, really the one that I think it's a masterpiece. And it looks at the first 20 years of this century, plus the 10 years of the last century. And there's a figure one which we need to improve, but actually shows the key milestones over the last 30 years in the fight against malaria. I think the key messages are that since the year 2000, there's been substantial progress in reductions in disease incidence and mortality rates. This has resulted in more than 7 million deaths averted and 1.5 billion malaria cases, so very substantial impact. Most of that happening in sub-Saharan Africa, and that's again really important to capture, that an extra 20 countries have interrupted malaria transmission within their national borders. I think 11 of them have been certified malaria-free. And so all in all, great progress. However, the World Health Assembly approved in 2015 a global technical strategy that laid the ground for the following 15 years, established 5 years milestones against the goals of reducing malaria morbidity and mortality by at least 90% by 2030, and a number of countries interrupting transmission. It is fair to say that over the last 4 years or 5 years, progress has stalled, funding has flatlined. In the last 5 years, in the first 5 years of the GTS, the reduction in incidence of clinical malaria is, if I recall rightly, around 3%. In mortality, it's about 20-something%. And so we have fallen short of our targets for 2020. And we are what we refer to as being off track. So we are, the malaria community, the malaria problem is not on track to meet our ambitious goals of 2030 or 2025, and we have fallen short of the 2020. Now,
I just put up an illustration there for this off track.
Yeah, I don't quite see it yet, but yeah, there you are. So the blue line is the trajectory, the actual data that we have followed in terms of disease incidence. The dotted green line is the trajectory we should be following since 2015 if we were to meet the globally agreed targets. The light blue line the light blue dotted line shows the if we continue at the rate at which we are, the trajectory that we will be following up to 2030. And so the delta between the two lines keeps on increasing, and we are seriously off track. Not just a little bit, but seriously off track. So the chapter 1 and the figure 1 of the World Malaria Report reviews key milestones. And I would like to retain a few key elements. Number 1, most of the innovation and tools that we're using now stemmed from research in the 1980s and 1990s, when there was very little financial support for malaria research, and Honorati Masanja and many at Ifakara can attest to that. And so insecticide-treated bed nets, it comes from the 1980s and 1990s. ACTs come from the 1990s. RDTs, by and large, from that same time. And so there's a slight paradox here, and that is that when there was very little financial resources for malaria research, the key commodities that we're actually distributing now come from that time. While in the better part of this century, when structures and financing has been a lot greater, we have not really come forward with any significant transformative tool. Number 1. Number 2, starting from the Amsterdam conference in 1992, the first conference that brought together ministers of health on to think specifically and develop a plan on malaria. It hadn't happened for 30 or 40 years. That triggered a whole movement that was basically led from Africa by ministers of health and heads of state in Africa that landed in the Abuja Declaration of the year 2000. Right. And around that, a set of G7 meetings, and eventually the foundations for the RBM, which was a WHO initiative, hosted initiative, as well as eventually the development of the Global Fund and other funding mechanisms. But it was the political leadership from Africa that made the real difference. So the 1990s, I think, show a key driver, political ownership and leadership from Africa. The only reason why malaria is part of the global fund, which was going to be only HIV, was because Africa wanted it to be there. And it just reminds us of how critically important it is for, beyond rhetorics, beyond political correctness, that African scientists, but also political leadership in countries, exercise that leadership in the international stage. If it wasn't because of that, there wouldn't be a global fund that contemplated malaria. There would not be the massive impetus that we have seen over the last 20 years. So the final, I think, key message I would retain is, and this is best seen by a slide like this one, doing the same thing over and over again with the same resources and the same tools is not going to get us very far. And I think as a community, we have not performed as well as we should have in terms of the research space.
Yeah.
If we're really serious about bending the curve, we need improved health systems, no doubt. We need to reach those that are unreached, as Elizabeth was saying before. The fact that we have close to 1,000 deaths, personally, I think it's a lot more, but we don't have the data to show that. If we really want to make a massive difference, we need improved health systems, we need to reach the unreached, and we need new tools. With the tools we have right now and the approaches that we're using, I think we see the limits of what can be achieved, but we have plateaued at an unacceptable level. And so this should be a call for a massive plan, funded plan, to invest in research and development of new tools.
So the point that you raised last about, so you raised two very, of the 3 points you raised, there are two that I think would like us to focus on a little more. First is the technologies and innovations that came out of the 1990s that we're still using today, and the lack of any new thing in the 2000s. Second point is just how much we have been doing the same thing over and over again. And in the next slide, as you can see there, we have one such example. Today, 2.2 billion bed nets have been distributed or are in use. This number keeps rising. This is our primary malaria prevention tool, but the curve is flat at the moment. I guess the question perhaps best for Patrick here is, if you look at this, of course, there is a great argument that if we didn't have the bed nets, the situation would be worse. But if you just look at the simple observation that we have 2.2 billion bed nets now produced and delivered, and yet the curve is flat, what lessons should we take for the next decade with regard to this particular intervention or anything else that is related to it? Patrick.
Thank you very much. And thank you again for the kind invitation. I think the fact that the curve is flat really represents maybe some a lingering uncomfortable situation, to use what Pedro described, where malaria, I think, is still relatively a neglected disease. But we've made much progress since 2000 with tools that were created in a time when resources for malaria were very scarce. Sometimes in my culture, a saying is that necessity is the mother of invention, that you're more creative when you absolutely need to be than when resources are coming in. I think also since 2000, much of the resource available for malaria have shifted to support procurement and distribution of the commodities that were proven in the 1990s and 1980s. And so I say malaria is still neglected because our global technical strategy, for example, has only been funded at the most at about 50% of its projected need, even in those years where we're attracting historically high levels of resources. And we still have an unmet need in terms of bed nets, diagnostic tests, insecticides and spraying programs and ACTs. And so I think countries and their advisors are reluctant to shift resources away from what we've been doing so far, simply because we haven't achieved our coverage goals. And I think the challenge is that we really do need a major influx of resources and attention to be able to develop new paradigms and implement them in a way that would really shift things. We can do some, and WHO has initiated its high burden to high impact strategy, which emphasizes how best to target the tools we have to the places where they'll do the most good. But I think, when I teach my privileged North American students from Columbia University, they've come through sessions on global health by the time they come to my course on malaria, and they've heard how the focus on vertical programs and programs like HIV, TB, and malaria are consuming the lion's share of resources for global health. Right. And so they come in expecting that malaria is lavishly funded and that we're making extraordinary progress. And so I have to sort of disabuse them of that notion that we're an entirely vertical program, or that we have or that we're awash in resources. We're really, most malaria programs in Africa are still struggling to meet their coverage goals for the key core interventions.
Can I come in, Frederic?
Yeah, go ahead.
So, because on this slide, I think our narrative of the great progress over the last 20 years, and although it's plateaued over the last 4 or 5 years, is a true one. But perhaps something I should have also mentioned, and this is captured in the graph you're showing, which I think again points at other elements that we need to be fully aware of. We estimate that 20 years ago, in the year 2000, there were around 200 million malaria cases in sub-Saharan Africa.
Right.
20 years later, we estimate we have just over 200 million malaria cases.
Yeah.
So although it seems paradoxical that there's been a reduction in disease incidence and millions of lives saved, the absolute burden that health systems have to deal with remains unchanged $40 billion later. And this is a product that, in this case, sub-Saharan Africa population has basically doubled over the last 20 years. So while, of course, disease incidence or mortality rates are an adequate metric, from a public health perspective, the absolute number, the burden that we have to deal, we have made no progress. And yes, 2.2 billion bed nets are great, and we need to increase that coverage where possible, although we're finding it very hard to do so, mostly through vertical campaigns. But we also need to remember, and you know this better than I do, that, I mean, Elizabeth was saying malaria is an entirely preventable and treatable disease. Well, actually, it's not. It is not an entirely preventable disease. We have very imperfect tools for the prevention. We have good treatment tools if the patient arrives in time to an adequate health facility where quality diagnosis and care can be assured. And they need to arrive on time. And many of us have had the experience for many years that patients arrive You can give them the best treatment and they will still die because they arrive late. So it is mostly treatable, but our prevention tools are massively imperfect. In the best of circumstances, insecticide-treated bed nets reduce by whatever, 40%, 45%. Clinical malaria. There's an extra 50 or 55% or 60% of episodes that are not prevented by insecticide-treated bed nets. And that's our core, our central, the backbone of our prevention efforts. So we just need to acknowledge and call out that from a disease prevention perspective or an infection prevention perspective, we have very, very imperfect tools.
Let's listen a little bit to Elizabeth on this. And actually, Elizabeth, as we look at this, there's something I want to show you, which is this publication here. And Pedro, I noticed that you co-authored this paper with Azragani's group in 2016. It was very well predicted that the graph would flatten around this time. So actually, the results that we see in the 2020 malaria report should not be in any way a surprise. And I can see that in the blue line here is what would happen if you sustained the initiatives that we had at that time. I mean, Elizabeth, at this time, you were still the National Malaria Control Program Director in Kenya. So maybe you just left. You're muted. You're muted, Elizabeth. I guess a question for you as someone who has run programs like this, is there a mismatch between the evidence available for the interventions, the guidelines that are available from the policy developers, and what is possible at country level?
Oh, thank you, Fredros. I was laughing in silence, deliberately. Two things. The guidance is adequate. Operationalizing it optimally is not adequate. And this varies depending on where you are. Optimal operationalization is fraught with many challenges. It could be logistics. It could be the systems under which we operate. It could be things entirely out of the hand of the health system, as it were. Disruptions, civil issues in the countries. These are all challenges programs have to deal with on a day-to-day basis. Supply chain management, reaching the unreached, poor infrastructure, trying to get to the last mile in a timely manner to be able to reach the populations that you want to reach with interventions. All these are challenges. And one of the things that, even though it is believed that a lot of the financing that went to, HIV, TB, malaria, is 40 billion that could have improved health systems. Parts of those health systems that were strengthened was commodities. Commodities, ensuring availability of the commodities, and to some minimal extent, capacity building and temporary hiring of health workers that would have to be absorbed by the national systems, but in most cases did not really get absorbed. So we went from up and down. These are real challenges that the health systems continue to face even now in the era of COVID. And we see if we maintained that level, that we only finance commodities and delivery of those commodities, but leave other parts of the health system, which granted a lot of those financing mechanisms were not really meant to address from the word go, then we would truly flatline. The funding has reduced. The great success also motivated a lot of funding, pockets to sort of dwindle. And so we are trying to do more in countries with less and still achieve some of the expected impact. And of course, there is ways in trying, can we better increase efficiency in the way we deliver these resources? But malaria as a disease is entirely dependent on the strength of the national health system, particularly in burden reduction to function. So if the health system fails, then we also lose the momentum, we lose the delivery in terms of delivering, getting to reach the populations that we need to reach. So I agree with the findings of this paper. And this was also highlighted in the global technical strategy and the advocacy documents that followed it, that we really, really needed to increase the momentum of the health systems needed to be strengthened to be able to deliver these services, in addition to increasing efficiencies of how we deliver interventions, like, I'm sure my colleagues will
Thank you. Yeah.
More about this, the stratification going blankets, in all areas. So in brief, that is what I would contribute to this. Thank you. Over.
Thanks a lot, Elizabeth. Patrick, we're going to come back to Professor Pedro on this, but first, Patrick, and my colleague Sheila is on the line. She's got a number of questions related to the modeling process here, which is going to come next. But Patrick, first of all, you worked a lot on the health system structure. I remember your time in Africa, in Tanzania, working with us, and ensuring, for example, access to treatment. I remember the cascades that you guys used to draw with Marcel Turner about how medicines such as ACT with 95% efficacy, 99% would eventually result in just 36% effectiveness. What would you say in response to what Elizabeth is saying in terms of layering a strong health system before we start talking about commodities? Is this even possible?
I think it's possible, and I think I agree with Elizabeth that it's essential. Commodities, essential drugs, diagnostic tests, bed nets, they are a critically important component of the health system. Without the intervention tools to prevent, diagnose, and treat malaria, the health system wouldn't be effective to begin with. You need those basic tools in the hands of community and facility-based health workers. But the systems building blocks that WHO has outlined in its framework for health systems also include improving the quality of service delivery, investments in the health workforce, the health information system, financing, and leadership and governance. And those things are more broad-based kinds of investments that sometimes our malaria-specific funding or our HIV or TB-specific funding can be restricted from even contributing to. I've lived for the last 2 or 3 years, at least part of the time, in the world of universal health coverage and primary health care development. And I find that there too, there's something that really, that I find really challenging about working in that space. And that is that just trying to build governance and just trying to build adequate health workforce and quality of care is a little bit unfocused. And so the investments are unclear. The strategies to improve things are don't necessarily have the same power of evidence behind them. And I think that somehow within the global health community, we've still perpetuated this disconnect between the disease-specific or vertical global health initiative diseases and the broader health systems elements. And I really think that malaria is in a good position perhaps to lead the way, that building those extra commodity or those soft elements of the health systems in support of better quality delivery of malaria services may be a better way of approaching the health system strengthening challenge than trying to do it from a more generalized or unfocused kind of way. But I think that requires new resources and new priorities on the parts of countries and their development partners.
Thank you. Thank you very much. Pedro, if you don't mind, I know I would like us to bring you back onto this. First question here is how you would, so this is something that you guys did in 2016. You very much could foresee what was going to happen in 2020. Perhaps not very accurately, the error around those lines are quite huge. Going forward, do you think that the global society will be willing to invest more on this health system issue?
Como ya conoce Pedro Alonso.
Go ahead.
Pero dije amigo, no.
I'll mute them. Okay.
You've muted me.
Oh, did I? Go ahead.
No,
Sorry about that.
So your question was, in the face of this, would the community will still be ready to invest?
What do you think the international community is ready now, having seen what has happened, to invest more on the health system components?
Yeah, that's a hard one. Perhaps a couple of disclaimers on these figures. This is the type of work that was done back in 2014 to inform the global technical strategy.
Right.
At that time, and that was before I actually joined WHO, but as an impact member, I was actually chairing the committee that was developing the global technical strategy, and actually Noor was one of the members of that committee. And there were two options. One was to let us establish goals and targets, as it is often done in the international community, which are a good guess or even aspirational. We've had to listen over the last few years, couple of years, people coming forward and saying, well, we will eradicate malaria from the face of the planet by 2040. Well, that clearly was aspirational. And at that time, we opted that we would try to root the goals and targets around metrics, and therefore avoid this aspirational nature of a target. And I'm not saying whether we were right or wrong, but the community usually establishes aspirational goals, and fine. And we said, no, let's try to get a little bit more detailed. And we triangulated three pieces of information. One, what was included in national strategic plans of countries. Two, an analysis of the trajectory that countries had been following up to 2014 and the projection forward of that. And three, some of the modeling work like the one presented here, in this case with the Imperial College folks. And it was based on that that we came up with the 90% reduction of disease and death by 2030, 35 countries having eliminated malaria and all countries preventing reestablishment of transmission. Now, one of the variables used were these models. Now, these models, when we now go back and reread them, and we did so just a few weeks ago, Noor and myself, and we went, some of the assumptions in the more optimistic models, the Accelerate 1, 2, and Innovate, but particularly the Accelerate 1 and 2, were clearly excessive. Like, for example, a 50% reduction in case fatality rate due to the introduction of rectal artesunate suppositories. Well, actually, there hasn't been any reduction in case fatality rate for all we know at all.
Yeah.
In fact, in some cases, some increases in case fatality rates, as our colleagues from Swiss DPH will be sharing in the coming weeks. So some of the assumptions have not held, and some of the assumptions were perhaps unrealistic. Now, so you're right. In many ways, the sustained line comes closer to what has actually happened. Now, the question here is, are models really that useful? Because we can take out a dynamic model like the Imperial College one and present you scenarios, which we're having to review right now and redo right now for the World Health Assembly in just a few weeks' time, that show what could be very ugly pictures by the end of this decade, if what they produce and they bring into consideration development of insecticide resistance, what could our morbidity and mortality picture look like? There are other models that, for example, the MAP models, that will not be going, that don't take this dynamic approach, but they do consider other variables like, for example, economic and social development and so on, models that we used in the Strategic Advisory Group on Malaria Eradication that present a much more optimistic picture. So it depends which model you use or you rely on. Now,
so just hold that thought. Just if you just hold that specific thought, because I believe this is we want to tie this up to a question that Sheila has on that specific point about different models. So Sheila, if you want to check that before Pedro finishes, that's the text.
Yeah, thank you very much, Fredros. Just like Fredros pointed out, so in relation to the previous slide and the previous discussion, Professor Pedro, there's a rise in availability of modeling data. So is this a consequence or a cause? So can we say that we are seeing an increase in modeling data because we don't have real data?
I think when we talk about modeling, and I mean, I'm not the best person to talk on this. I know that there are others in the audience who are much better placed. So modeling can be used for different purposes. One of them could be in projecting what is the likely evolution of the disease given certain parameters over the next 10 years. Another one could be to potentially predict impact of the deployment of a new tool like a malaria vaccine. The key elements include what are the parameters that are being introduced. Like, for example, and this would be a question for Pedro, do we entirely understand the rates at which insecticide resistance would be developing and the public health impact that this would have?
No.
Or when a model comes out with outputs that have considered those variables, are they based on real data, and how hard is that evidence? Now, finally, to your question, Sheila, I mean, the other area where we use models is in, for example, estimating the burden of malaria in areas where we don't have good surveillance or quality surveillance mechanisms. And in that case, that's a very clear area where we would hope that we wouldn't have to rely on models because surveillance data would be good enough. So the World Malaria Report, in areas of mostly low transmission and outside Africa, by and large, relies on real data. For most of the high burden countries in Africa, we rely on modeling. So in this case, very much to your question, models are used because we don't have really good data. In other circumstances, we use them because we need to project impacts or evolutions of given conditions or diseases. Does that help?
Yes, thank you, Professor. And just a follow-up question. You mentioned something about surveillance, and in the current GTS document, we see that there are plans to sort of operationalize surveillance as an intervention by itself. How do we make this possible? What are the ways in which we can accomplish this?
Well, yeah, the 2015 World Global Technical Strategy established surveillance as a key pillar, as one of the 3 key pillars in our global malaria strategy. Without good data, there is no good malaria control. And this is an area that is massively underfunded and speaks very much to what Patrick and Elizabeth were saying before. In order to have good surveillance, you need to have good access to quality health systems. And the 2 things go hand in hand. The fact that we need to continue estimating the malaria burden through applying a model that transforms parasite prevalence to incidence, parasite prevalence being derived from household surveys and so on, rather than actual cases diagnosed by a health system that has sufficient reach to ensure access to those in need is a massive shortcoming. So we need to decisively invest in surveillance systems, and we need to decisively invest in health systems, without which there won't be further progress. And that is perhaps one of the problems, and I totally agree with the way Patrick has framed this. There's been a little bit too much a commoditized, and I know Pedro has written around this. Malaria control has become a little bit too commoditized. Of course, we need commodities, but those commodities need to be used within a functional and quality health system that is not there yet. And thus, greater emphasis and investment on the health system is essential.
Do you think we should be embarrassed that in 2021, we are still relying on mathematical models instead of real data?
I am very embarrassed. I think we should all, as a community, be embarrassed. I mean, we report in the World Malaria Report, only 30% of febrile episodes get to be diagnosed and treated. There's a massive lack of access to a functional health system, and thus there is a massive lack of real data as to what the problem is, and thus we need to rely on parasite prevalence data and their subsequent model to incidence.
Thank you so much. Sheila, do you have additional questions?
So we can move forward, Fred.
We can move forward. Okay, so here is an example of, forgive us for blowing our own trumpets, but my host country, Tanzania, is one of the few countries that appears to be, doing better in terms of using local data to inform decisions. They also use a lot of modeling. And here is an example of in-country subnational stratification. This is work done by National Malaria Control Program and partners. I know Emily is on the call, and Manuela and Sumaya. This work has been very instrumental in informing the development of local strategies in the country. But it's quite intense mathematical modeling combined with a lot of data collection from many, many different facilities and schools across the countries. Now, perhaps a question to either of the three of you. Is this something we should be encouraging the national malaria control programs, all of them, to implement? Or are there alternatives that can be used just by taking a generic information from other countries and saying, let's do this instead of having to do our own intense stratification? How can we use the example from Tanzania to improve malaria response across other countries?
Pedro and dear colleagues, Elizabeth and Patrick, do you mind if I start briefly? Because then I will need to go on to another call and then try to come back. But I feel so strongly about this, Fredros. I think Tanzania has shown amazing leadership. This is what has inspired the key component of the high burden to high impact initiative of WHO. When we talk about we need to move on from a one-size-fits-all approach, we refer to exactly what you're showing right now on the screen. We've been used for too long to just quantify all the population, how many bed nets, and everybody. We aim to try to get everything to everybody. And while that may have been a useful thing to do at the beginning of this century, we now need to become a lot more efficient and effective in the deployment of our tools. And this has to be informed by data. Not everywhere is the same. Heterogeneity of malaria transmission is very significant. And as transmission intensity goes down, the heterogeneity further increases. And the concept of stratification is not a new one. It was in WHO already in the 1950s. And to some degree, we had forgotten this. And therefore, the use of data to identify, and indeed you do rely in some degree to some modeling, to identify the optimal mixes of interventions and project the potential impact, and then putting it within a given resource envelope, I think is one of the few things we have at hand to effectively improve our current situation. And the leadership of Tanzania has now inspired our work from WHO and many others. And this same process, we're carrying it out in a number of other countries and informing national strategic plans and its subsequent translation, hopefully, into concept notes and funding by the Global Fund. So this is what we mean when we need to move away from a one-size-fits-all approach. And this is a journey that you all started in Tanzania. We're following in other parts of Africa and other parts of the world. And we can refine it even more. For example, urbanization. And we hope to convene a substantial meeting in the coming months, because that's a phenomenon that we have not paid sufficient attention to. And it's, large percentages of population now live in urban areas. Is that the same? And I know there was the case about Dar es Salaam in this process. So enormous thanks to Tanzania. We take this as a key element of our potential to progress in the coming years. It will be reflected in the updated global technical strategy that is going to be tabled at the World Health Assembly. And in many ways, Tanzania led the way.
Congratulations to the NMCP and the partners. I hope that a number of them are on the call here. Mm-hmm. So I think it would be a great message for them. Go ahead, Elizabeth.
No. Fredros, before Pedro leaves, Abdisalan Mohammed and myself will say Kenya led the way. We started subnational stratification and using stratification to determine where interventions should be placed way back in 2009. And I dare say that the rest, this sort of led the way for the examples. Of course, Tanzania have taken it to a bigger level, and we agree, but we need to share the spotlight with in terms of use of stratification and use of data for decision making. And this comes down to what I was going to talk about, the efficiency of information, of implementing strategies, particularly in resource-constrained situation. How best can we do this? And data becomes very important. You use the best available data. And for me, the example of Tanzania, and also just to give from our own experience, was that we had blanket implementation of interventions such as intermittent preventive treatment in pregnancy, and also LLIN distribution, even in areas where there was no malaria transmission at all. And this was really not good use of the available resources. So using this subnational stratification, availability of data, using tons of data collected from way back when, and even commissioning new data collection, we were able to make subnational categorization of areas, districts to which this could be implemented. Now we are encouraging this to even go to the sub-district level so that we are able to identify who exactly is at risk so that we can target these populations. Some of them may not even be seen by the health system, as Pedro said, so their information may not be available. How best can we collect this data to identify those risk populations, ensure equity? It might be rights issues, it might be an equitable access issue, it might be gender related, it might be migrant populations or mobile populations that nobody really knows how to target from these fixed service delivery point delivery systems that we have. And this is one of the things that we need to take forward. And I see in the chat a lot of discussions on integration, integrated vector management, and what we can do with vector control. Subnational stratification like this can help us determine what areas are we able to address issues around environmental management, mitigation of their projects in areas. And we need the projects for economic development, but are we mitigating the health impacts of these projects, particularly in sub-Saharan Africa, where these
Elizabeth,
and how can we help them to mitigate?
Yeah, just to say, Elizabeth, just to say that Abdisalan Noor reminds me always that Kenya did it first.
Yep.
So, but I think it's probably fair to say also that in the recent years, the most comprehensive nationwide analysis has been Tanzania. But we'll acknowledge that you and Noor did it many years ago in Kenya.
I'm happy to hear that kind of a fight, actually, because it's a good fight.
Yeah.
It's I would wish that we had 3, 4, 5 more countries arguing about who did it better,
right,
who is doing it fast. So Patrick, please. Because Pedro is leaving, we're gonna
invite Abdisalan Noor to join on video. And if you don't mind, please come on in. Patrick, come on.
Yeah, I'm equally proud of Tanzania and Kenya, although I can't claim any role in either country's accomplishment here. Maybe, though, I would like to draw some attention to my first home in Africa, which is Nigeria. And in the 2020 World Malaria Report, you can see that Nigeria has done this as well. And so it's followed this example in a much larger and more complex kind of situation. I think there are a couple of themes we talked about that really are reflected here, and I want to point them out. One is that back in 2000, when we started down this road, we did everything we could, everywhere we could afford to do it, to the extent we could afford to do it. And so we had blanket policies about ITNs, intermittent preventive treatment, case management. And at the time, the standard for diagnosing malaria was anybody with fever who lived in or came from an area where malaria transmission occurred. So we had health information systems that were generating case data, but it really wasn't useful to us because it was purely, there was no diagnostic testing in the vast majority of cases. It's only since 2010 that we've had a global recommendation for diagnostic testing that's been made possible by the availability of rapid diagnostic tests. We rolled those out primarily because we were concerned about wasting our precious investment in ACTs. But a side effect of that is that it created an opportunity to have information about diagnostically confirmed cases, which is suddenly way more meaningful and way more useful for planning national strategies and for assessing the impact of our interventions. So I think we're at the very start of what could be a really exciting next decade or so as we unleash the potential that creates for this kind of subnational planning and assessments. But again, it requires attention to making sure the commodities are there, but also that the system functions to the extent that people want to come to the health facilities where they get a diagnosis and a treatment and their illness gets recorded.
Thank you. Thank you so much for that. So Sheila is going to take this forward, but first I would like to invite Professor Noor. Could you kindly just turn on your video, please?
Hi, Fredros.
Thank you so much. Many questions relevant to you, but anyway, for now, Sheila, please.
Yeah, thank you, Fred. Thinking about the map that we've just seen and the discussion that we've just had from Tanzania with respect to stratification and use of vector control interventions or distribution of resources. So the current practice is that vector control interventions should not be scaled back in areas where there is ongoing local malaria transmission. But when we do our stratification, we can see that from the example that we just had, we can see that there are some areas that have very low transmission. Fred, if you could go back to the map, yeah. Thank you. So my question to the three of you is that how can we safely scale back some of these interventions? So for example, if we were looking at an area, say in Tanzania, and an area that is currently implementing IRS, and there is very low transmission, and there is probably also outdoor transmission, how can we safely scale back? Should we be thinking about options of probably replacing IRS with ITNs? Can that be done safely? Or sort of which kind of data would we need to have such information or to make such decisions?
Okay.
Elizabeth, do you want to start, or I'm happy to?
Likes to go first, if he's still on.
Hi. My response to that, I think there are two parts to that question. The first one is, are you scaling back because you don't think vector control is useful there? Or are you scaling back because you have limited resources and therefore you want to spend your resources in such a way that you get the biggest possible impact for them? And I think how, depending on what problem you're dealing with, you have different pathways in terms of the response. if the question you're asking is a philosophical one, where you have ongoing transmission, should you still continue implementing vector control? I think most people will say you've got to do that. Which vector control depends on the context you're dealing with and the type of vector you're dealing with. But if you are talking about what to do in very resource-constrained settings, which is a problem we're dealing with quite a lot in most of the high-burden countries, then I think inevitably you'll have to think that way. And you'll have to decide on how to optimize the impact of the limited resources that you have. And in many ways, it's the decisions we had to grapple with when we made the analysis. We did the analysis for Kenya in 2009, 2010, when Elizabeth was still the National Malaria Program Manager. And it wasn't that the places where we scaled back did not necessarily need bed nets, for example. Some of them did, some of them didn't. But there are places where we knew bed nets could still be useful, at least at the individual level. Their overall population health impact might not be that high, but we were in a situation where there weren't resources to cover everyone. And in that kind of situation, you have to aim for where you're going to get the biggest impact for your resources. And that might mean that you put bed nets in the places where you're collectively going to buy the biggest gain. If you speak to some people, even those who resist this kind of an approach, and then you ask them, okay, tell me how you're going to distribute 20 million nets where you need 60 million nets to cover everyone. The approaches have been, we will give 1 net for every 2 persons in the very highest transmission areas, and then we will start giving 1 net or 2 nets per household after that, or again 1 net per household or something of the sort. And there's a psychological element to that, but when you actually then look at that from an impact perspective, it might be better you cover the very highest burden areas well, and you potentially do other things like ensuring that you have really good access to care in those other places to minimize. If you cannot prevent infection adequately, you minimize the risk of severe disease and death. Those are the kind of things you need to potentially think through. So I'll leave it at that. The question is complex and it's very context specific.
I think too, Noor, one of the things that I've learned from you is that having timely, good information will also be valuable in this respect as well, because it will alert you to situations where you need to address a deficiency that might occur. Most
Absolutely.
countries that have stratified and have taken this targeted approach, they haven't abandoned vector control in any places within the country. They're still providing IRS or nets. They may intensify, they may rely on every 3-year national campaigns in parts of the country. And then in those parts of the country where there's a higher burden, intensify their efforts in the routine keep-up strategies or school-based strategies or community-based delivery strategies to ensure very high coverage in between those campaign years. And so I think we haven't yet been in a situation where stratifying and tailoring subnational programs has resulted directly in eliminating or pulling out of vector control altogether. When we get to the point of elimination, that can become a consideration.
I think, Patrick, to add a point to that is that in certain places, in some of the high burden countries, there have been, and in fact in Kenya, we made this decision nearly 10 years ago, not to put bed nets in some places of any form of vector control. However, the point that Patrick raises, which is in places where you're not totally sure as to what the consequences of scaling back will be, you need to have a very strong surveillance system to alert you to any potential changes or increases in the burden, so that you can mount a targeted response. Now, in the discussions for the HBHI countries, there hasn't been a time when, except perhaps in maybe places in Tanzania, maybe some places in Mozambique, in most other countries where there isn't such a diverse heterogeneity, the decisions have largely been around what to do between urban and rural areas. Some countries had already decided to scale back bed nets in urban areas, particularly mass campaigns, and might keep routine distributions.
Thank you.
Others have opted to be a bit more conservative, and they want to do detailed urban microstratification to understand risk better, so that they can be a bit more targeted.
Yeah.
So there are many ways to approach this.
So I think we can carry this. We have some questions that are related to how we will balance case management and vector control in different epidemiological settings. We have this coming up soon. Before that, I would like us to turn to a different subject, which is on resistance, drug resistance in this case, not vector, not insecticide resistance. So, Patrick, you worked a lot on drug resistance as well, and you currently serve also at the WHO Global Malaria Policy Advisory Group. And the question of ACT resistance has until now been restricted mostly to the south, to the Mekong region. But you know, we occasionally see reports from certain parts of Africa of the K13 propellogens detected. I hope my colleague Deus Shengoma from NIMRI is here as well, is looking in the northwest of Tanzania whether we have any signals there. Some work from Rwanda seems to suggest that you have a de novo rise of resistance markers in those regions. The question for us here is, should we worry about ACT resistance coming to Africa anytime soon?
We should be vigilant for it. Resistance, as a biologist, Fredros, you know, resistance to insecticides and resistance to drugs is a biological inevitability when you apply those drugs or insecticides widely to the parasite or insect population. We have used strategies like combination therapies to help mitigate against the selection and perpetuation of those, and that has served us well. The biology of artemisinin, the fact that they've such a short half-life, may have also contributed to serving us well, to not creating a long tail of elimination where we are selecting for drug resistance parasites to be transmitted along. But I do think that we should be alert for it, and we should not be surprised if and when it might take hold on the continent. And we should be investing in additional mitigation approaches, as well as potential new combinations and new treatments. What Africa really faces right now, however, that may be more pressing, is the potential for resistance in some of the partner drugs that we pair with the artemisinin drugs. And so being cautious to understand that as well, and understand where combinations with artemether lumefantrine or combinations with DHA piperacin or some newer combinations might be better deployed to help contain the potential selection and spread of resistance to some of the partner drugs is maybe the more immediate concern, because we know that is actually being detected in multiple places.
So in terms of treatment options, Go ahead. Yeah. Someone try to.
Yes, I just wanted to complement what Patrick has said, and yes, we do need enhanced vigilance for efficacy of antimalarials on the continent. It's true, we do have confirmed reports of parasites containing validated mutations that confer partial resistance to artemisinin. But also, and this, of course, the Rwanda situation that you mentioned, but we've also had suspected, other de novo mutations that have arisen in Uganda and in countries in the Horn of Africa that are validated or suspected. So we do have a threat right on our doorstep. It's not just in the greater Mekong region. And the importance of the continuous therapeutic efficacy monitoring cannot be overemphasized.
Right.
The nature of oh, go ahead.
Helps us detect.
Yeah, I think we're losing Elizabeth a little bit.
Sorry.
No problem.
I was going to add that the nature of the drug resistance or the nature of the artemisinin resistance that we see in Southeast Asia is not the kind of absolute clinical failure that we saw with chloroquine or SP in the 1980s and 1990s. Pedro, if he were on the line, might say, I've heard him say it in the past, that even in Southeast Asia, no one has actually died of artemisinin-resistant malaria because it's still curable with the right combination of drugs.
Yeah. I noticed that the WHO documentation actually refers to it as partial resistance and not like full resistance. But it's good to hear from you that, at the moment we don't have this problem yet, but we need to be vigilant. One point that you might want to stress on, just for clarification for myself and my colleagues here, is the issue of resistance to the partner drugs. So what exactly are you talking about here?
When we talk about resistance to partner drug, I mean, it's a combination treatment. It's combination treatment. So in the efficacy studies, we need to monitor efficacy to both the artemisinin, which, as Patrick has mentioned, has a very short half-life and provides the rapid reduction in parasite load in the first few hours of treatment. And then we have the partner drug, which continues to clear any arising parasites over the next 7 to 14 days. If we have resistance in the partner drug, what you may find is that then you start getting recrudescent infections. Those parasites that were not cleared by the partner drug will, grow again because now there is no artemisinin in the blood. And then we will have, a recurrent infection or patient comes back with parasitemia. And this is why the efficacy studies will help us determine whether any recurrent infections are new infections or they are recrudescent infections because of a challenge with the partner drug. So either way, the efficacy studies are very important. And if the partner drug fails, even if the artemisinin is effective, we do need to change the ACT regime in that particular area. And there is WHO guidance that is very clear on this, that once the failure rates go to 10% or more, we need to change the ACT in that particular area. So you cannot know whether your medicine is failing or not until you really do conduct these studies. And that's why they're not really clinical trials, but routine surveillance, part of the routine surveillance that's carried out every 2 to 3 years to help inform policy decisions with respect to case management.
Oh, no, thank you so much. Before we proceed, I just want to check if my colleague Sheila has any additional questions on this.
No, Fred, you can move forward.
Talking about MDA, but let's move a little bit to this question of what do we put in place when we are chasing malaria elimination or eradication. So I don't want to cause any controversy here, and I'm glad, partially glad that Pedro isn't on the call right now. But referring to the Lancet Commission, you remember the story of Lancet Commission? They're saying malaria is eliminatable, and actually we should go for it within this generation. They do have a statement there, malaria eradication is possible. They also make the point that from the beginning, nearly half of the countries that used to have malaria no longer have malaria. But then in the analysis that they present, there are two parts which are very interesting. One is some kind of modeling that suggests that economic developments have played a big role and will continue to play a big role in malaria eradication game or elimination. However, when they put forth what their proposals for going to eradication should be, they list the following. This is what you see on the figure there. And if you read that, you do not see this socioeconomic development in question. You do not see this environmental management questions they're talking about. They describe it in detail in the modeling work and suggest that it is indeed one of the major reasons that malaria is disappearing in many parts of Africa. But when they make a proposal for how to get to eradication, they list the following items here: mostly tools, mostly commodities. Health system strengthening appears there very little. Socioeconomic development appears there very little as well. I am wondering, from a very big picture perspective, from you, Patrick, Abdisalan, and Elizabeth, if Shell and myself were to ask you, is this a case where scientists have become too dogmatic, or is this a case where certain things are just not within the understanding of the experts, so much so that we just don't think about them as options for malaria control?
I would maybe take up your point that very often when we look at the successes of the mid-20th century malaria elimination efforts in Southern Europe, the Southern United States, and across the Caribbean and other parts of the world, we very often attribute it to the widespread use of DDT and the widespread availability of chloroquine as a treatment. And those technological developments were probably important. Sometimes we even cite the strategy of reducing breeding sites through land reclamation and flood control and things like that. But in actual fact, superimposed on all of that were increases in socioeconomic status and improvements in access to functional health systems. And so I think our story of what happened in the Southern United States, in particular Southern Europe, is sometimes overlooks the important role that socioeconomic development had and that improving people's access to health systems had. And so it makes it, I think that this slide may perhaps just recapitulate that oversight of the role that technology versus broad-based development had in the 20th century, and puts it here. As a malariologist, I'd be thrilled to have any of these tools available to us. And I hope too that as a global citizen, we're also pursuing socioeconomic development on behalf of the marginalized and poorest people who suffer the greatest burden of malaria. I think we do need to approach both things together. I don't think that we will achieve malaria eradication in a generation. without new tools, even if we were to have transformative social and systematic change.
Thank you, Patrick, and I agree with you. The document or the paper was written based on the experiences of those who went through it, but they forgot that in many parts of the world that we live in now, where the burdens are highest, the socioeconomic development is still very low, and the health systems are still quite weak. And we know that without these two, it impacts the way we are going to, or the way we can deliver some of the suggested tools, even if we have the most perfect medicine that we could deliver right now. If you don't have a health system that is accessible or that reaches everyone at risk, then we will not be able to deliver the tool and achieve the impact that it promises to deliver. I think, and it reminds me of an argument that I had when we were at the ministry, and the demographic and health survey for Kenya in the late 2000s had just come out, and there was this remarkable reduction in child mortality. And of course, among the contributions was, of course, the reductions, access to immunization, access to ITNs, and case management. ACTs had just been introduced, and all these things. And someone at the Ministry of Finance said that, do you really believe that it's just your nets and your medicines and your vaccines that contributed to this? And we had to do a step back, and they said, look also at the other, indicators in the demographic and health surveys that sometimes we overlook, which is, access to things like electricity, running water, certain things that are used as proxy measures of improvement in socio-economic status. And look at that and say, how much did that contribute to the reductions in mortality? Because if these households did not have, maybe disposable income to bring that child to the hospital or to bring the child for immunization, would that child have survived? If there was no food and things like that. So we do need a critical part of improvements, or even the gains we need to make in malaria, will also come from the broader socioeconomic development. We don't know what urbanization does and whether the way we are doing it is going to be impactful for some of these diseases that we have, the communicable diseases and other NTDs, and whether we are, hopefully moving on in the right step to improving human development itself and reaping the health benefits from that. Thank you.
Thank you both so much for that. We're gonna move forward to this. Thanks for the clarification. Shayla, please.
So this question was to go to Professor Pedro. I'm not sure if any of our speakers would be able to help us answer this question. So it talks about the recommendations that have been put in place by WHO on MDA. So I think from the recent publication in 2020 by Pedro, this is an excerpt, like an extract from his publication. And he says that there are only there are only a few options for us available for us to enable us to achieve the full potential of MDA. So my question to the speakers is, how can we best achieve the full potential of MDA, given the recommendations that we have in place, and given the circumstances and scenarios that we have in place? in the different epidemiological settings?
Thank you very much for that question. And medicines, of course, in addition to case management, can be used for what we call parasite control, and what some people in the chat have told, what are we doing ourselves to target the parasite? Mass drug administration in itself for malaria, I think is something that people have heard of. We do have, medicines, ACTs. We do have medicines that are available currently that can be used. WHO has recommendations for MDA in both situations in emergency settings, but also in burden reduction settings and also in elimination settings. So MDA as an intervention using chemotherapeutic agents can be used for malaria burden reduction and elimination. But there is a big caveat. MDA is not just waking up one morning, rounding up people and making them take medicine and hoping that things will be done. As an intervention, there is also a manual that accompanies it that helps in the planning. And the key thing to define is, what is it that you want to achieve? What do you want to achieve with this intervention? How do you plan to achieve it, which is the actual intervention implementation itself, which requires, of course, a lot of engagement, much like planning for a lot of the vector control interventions that we do. Mass drug administration also requires that. And even more, it requires community engagement. It requires health promotion. What are we telling the population? After we have defined our objectives as the scientists and the technical team, defined and seen that this is the number of rounds or whatever that is going to be required to achieve our objectives, how do we now go back to the community and present our intentions and hear from them their feedback and get their buy-in? Because at the end of the day, it is an intervention that requires maximal cooperation from our communities in order to achieve the potential or the desired impacts. And where this has been done, it can be successful. We need to perhaps document a bit more how best to implement it, and different ways in which mass drug administration can be implemented. And indeed, there are forms of mass drug administration that are currently being used, like seasonal malaria chemoprevention in the Sahel. That is a form of MDA. It's targeting a specific group, and it is currently being used for burden reduction in this vulnerable group during the intense months of malaria transmission in that area. Do we need better medicines for mass drug administration? Definitely, yes. Would a single dose drug that would work for everyone would be most desired and would be perfect. Do we have medicines that we can use now and document their impact? Yes. Do we have the guidance to be able to implement these interventions in the different settings that we would like to use them? Yes. So I think all that is available, and we should be able to, get those who are willing and say, let's define what we want to do. This is how we want to do it. This is how we engage, get the resources, and see how best we can use this to achieve impact. Over.
Thank you. Thank you. Patrick, you did a review together with your colleagues on, this is a Cochrane review that you did, partly informing also the WHO guideline.
And
one of the challenges you addressed here was the issue of short-termness, if I may use that language. Could you talk about this? And also some of the issues that Elizabeth talks about, like, do we have the medication? Do we have the systems in place? Sheila was asking us what opportunities in different parts of Africa do we actually have to scale this up? Is it something just for low transmission, or is it for all the transmission status?
So I think those are excellent questions. And we had an opportunity to update this Cochrane review relatively recently as well. And it's forthcoming. But I think the challenge is that you can reduce malaria burden in a population if you can effectively cover a large portion of them with mass drug administration. But in areas of high malaria transmission, very often that impact lasts only 3 to 6 months before the prevalence returns to the baseline level. That's one reason why we talk about rapid reduction of morbidity and mortality in epidemics and complex emergencies. If you're doing it to reduce malaria morbidity and mortality for a short targeted period of time in the context of a complex emergency, for example, where you don't have the opportunity to get people to come into fixed health facilities the same way you do when security isn't such an issue, that it can be useful in that setting. And I think the other piece of the picture is that in areas where malaria transmission is moderate to low, that period of protection lasts a little bit longer, lasts up to a year, sometimes 2 or 3 years, just because it takes that much longer for transmission to reestablish itself to baseline levels. I think one of the other innovations, or one of the other things that Elizabeth points out, is how SMC is effectively a form of mass drug administration, albeit targeted very specifically to a specific geography and epidemiology and target group. But I think Pedro has been really helpful for me in sort of reframing my perspective on the use of drugs and in some cases diagnostics for chemoprevention. And if we think of chemoprevention as a set of strategies that includes the IPT that's recommended for pregnant women and sometimes for infants, the seasonal malaria chemoprevention that's recommended in the Sahel for children under 5, and increasingly being expanded to broader age groups, and the targeted use of whole population mass drug administration. Even chemoprophylaxis, protecting forest workers in Southeast Asia, the people who go into the forest and overnight there are the most likely to become infected with malaria. So providing them with either mass drug administration on their return or chemoprophylaxis to take throughout their stay in the forest in the risk area may be strategies that we underutilize in our malaria control programs in endemic countries.
Thank you. Someone just put on there, I'm kind of, someone just put on the chart there statement kitchen sink strategy. I don't know exactly what that means, but
well,
ahead,
I think sometimes when we reach the plateaus that we've reached, where we've tried our best to get our intervention coverage optimized, and we reach a plateau in terms of level of coverage and level of burden. Sometimes there is a knee-jerk reaction to go to the next potential strategy and to say, oh, let's try mass drug administration now. And I think you really should pay attention to the specifics of the recommendations, because it's not necessarily going to be impactful everywhere, and just throwing it in because it's the next item on a list of potential tools without carefully considering the context is a risk. And that sort of kitchen sink approach is potentially short-sighted. But we also have the situation, as Pedro described at the beginning, where none of our malaria interventions is completely protective or preventive or 100% curative. And so we actually need to think about layering interventions on top of one another to achieve meaningful reductions and to sustain gains and consolidate against them.
Oh, thanks.
Yes,
Yeah,
and just to add that, sorry, Fredros, you cannot use MDA to compensate for inefficiencies in your vector control interventions or case management interventions. So that approach to say, oh, okay, now, my cases are going high, we are not doing well, maybe we didn't get the coverage for net, so we didn't do an optimal IRS, maybe, oh, let's get medicines and do MDA. That will not work.
So on the points that you raised,
yeah.
Here is an example from Zambia. I believe both of you and Dr. Noor, if you're still on the call, I believe you've read this publication from PATH. Multiple rounds of vector control, 4 rounds of MDA. The question in focus here is whether mass drug administration is beneficial in a high transmission, and also whether it's beneficial in low transmission settings. Of course, statistically speaking, you do see some differences in the low transmission settings. Seems like MDA adds a lot of value there. But the mere fact that you have such good coverage of vector control means that you are already doing a lot more, that it becomes almost impossible to see the additional benefits of MDA. So I guess this is what Sheila was asking earlier. Sheila might be wrong, but I believe there's a second part to your question, which was, how do we balance this case management, the use of drugs either in case management or MDA form versus vector control in different transmission settings. So could you guys comment on what NMCP directors in Africa today can look towards? At what stage do they introduce MDA to achieve maximum benefit?
This is a very interesting study, and I don't think it is a matter of at what point, but I think just looking at this area in southern Zambia, if you say what brought everything together, and the answer to that is surveillance, the surveillance systems. They had optimal, they ensured optimal coverage with vector control interventions. Access to case management was good. In fact, there were community health workers working in this area, providing both diagnosis and treatment, but also, doing the surveillance aspects of notifying the cases, documenting the cases. So it was easy to see which villages had infections or where infections were coming from, and a response action like finding out what is driving infection in this particular area. So it's not like MDA will provide you the solution to all the problems, but you use it as an intervention. For instance, if you find an area where you say this is ongoing transmission, I have a reservoir of cases that is taking place in this area. We have done all we have optimally. If we do 1 or 2 rounds of MDA, we can eliminate this parasite reservoir and interrupt transmission. that is a decision to be made. So this, you can make it. I think it's important to distinguish the epidemiological setting and the level of transmission, how low or what level of transmission you're at, and then what exactly you want to achieve. Do I want to bring disease burden down and then maintain that low level using 1, 2, 3 other interventions? Or am I at a low level of transmission? I have different clusters of ongoing local transmission that I feel is coming up from a parasite reservoir. I have done all my vector control interventions. My surveillance is placed. I have identified this population. It is well defined. Can I use MDA as a form of parasite control and elimination to interrupt transmission? So that is what I would say for this. In the high burden areas, I think there is different objectives to be achieved and different metrics. You know, you often may not be able to circumscribe a population to target unless you're living off in an island somewhere. But if you're on a contiguous landmass, it may be difficult to sort of sustain the gains you want to make with MDA and to define exactly what you want to achieve. So in high burden areas, MDA is most often used in emergency response, humanitarian crisis, or certain events that overwhelm the health system in such a way that if you don't do something, then you're likely to achieve, to get untold morbidity and mortality from malaria. So you use it to, mitigate that. It can also be used, but the objectives have to be, and sustainability of your achievements have to be very clearly defined.
Thank you. Patrick.
I think, well, speaking of islands, our colleagues on Zanzibar, in collaboration with partners at Tulane University and Swiss Tropical Institute, have at least explored through modeling the potential for an approach similar to this, where they have a low transmission setting and they're thinking about undertaking reactive focal mass drug administration in the context
I just put up the slide for you on that one.
There you go. In the context of where they have identified cases, what they're finding now is many of the cases that they're registering are cases that are imported, that were acquired when people traveled to the mainland and came back, and that they invest a lot of effort in investigating those cases and looking for local transmission surrounding them and doing active case detection. And they're beginning to consider at least whether there would be an advantage to, when they identify a case, to providing focal mass drug administration to that household and all the households around it as a way of potentially reducing subsequent cases or secondary cases.
It's great that you mentioned that, because we were planning to ask you about it. And I'm wondering whether any of the colleagues from Zanzibar or anybody from Tanzania who is familiar with this system is available to explain further online. But this is something I would like to request you guys to talk a little bit more about. The proposal here is for something called focal reactive MDA. It's a new form of MDA. Instead of reactive case detection, you go over there. And I remember talking to Manuel Hetzel, and he was telling us at the time that the current system captures just about 3.2% of everything. That it's not, you don't get so much by the current practice. And that if you did focal reactive MDA, as they call it, you will be able to capture much of this undetectable cases and achieve much greater version. So is this something, I imagine that this is something that is suitable only for elimination settings such as Zanzibar. I don't think it's something that you could apply in high transmission settings. So is this right? And maybe if we have someone from this research group, Swiss TPH, Josh, or Tanzania, would like to explain this in a little more detail, please just just jump in and talk to us. Patrick, please.
Failing to see them, I think that they were recommending it for a specific elimination, contributing towards elimination efforts on Zanzibar. And that 3%, that small majority, is when they go out and using the current diagnostic technology, the rapid diagnostic, conventional rapid diagnostic test, they go out to investigate each case and conduct active case detection with the rapid diagnostic test in, I forget how many households, but let's say the nearest 5 households to the index household, that really they're based on a population level survey using PCR, there are many more infections out there than are being detectable by just the rapid diagnostic test. And if they had, instead of relying on active case detection, if they had treated everybody in a larger radius around that infected person's household, so instead of just going to 5 households, going to 10 or 20 households nearest to your index case and treating everybody, they would effectively cover a much larger proportion of the people who had evidence of infection by PCR. So far, they have demonstrated this potential through a model, but I don't believe they've yet actually implemented the reactive focal MDA intervention.
Thank you. Enough talk about MDA, case management, drugs. I would like us to jump back to vector control a little bit. As you know, a big proportion of our audience are vector control experts. And I'm going to ask my colleague Sheila to take it up from there.
Yeah, thank you, Fred. Yeah, so I think at some point there was a vibrant discussion about how to tackle outdoor transmission. And when we are thinking about this, especially in the Southeast Asia or Southern Africa, where the main vector control interventions are actually outdoor biting and outdoor resting. So transmission is happening outdoors. And so this sort of minimizes the efficacy or effectiveness of the main vector control interventions, such as bed nets and IRS. So in such scenarios, how best should we balance vector control and case management? How should we be balancing our resources in such cases where we still don't have very concrete or effective interventions that target outdoor transmission? Elizabeth, would you like to go?
Thank you, Sheila, for that question. The balance is that we need both. We need both case management, we need both and vector control interventions. And we go back to the issue of data and determining, you know, the kind of vectors that are active in particular settings, in where and in which seasons are they most active. Because yes, there's been a lot of information and a lot of documentation of outdoor biting, outdoor resting vectors that may not be targeted by our indoor vector control strategies. But also, they do not totally replace the indoor biting, indoor resting mosquitoes. And you find that in many settings, you will have a combination of both. And if you look at population behavior and interaction with vectors, then you also have a lot of activities that are continually taking place outdoors at all hours of the day. And then the next question is, how do we offer protection? And there has been a lot of discussions, I think I've seen on the chat in the chat boxes on integrated vector management and the suitability of this. Because if we target breeding sites mosquito breeding sites, or where and modify environments to minimize mosquito breeding. We target malaria vectors, but the benefits extend beyond malaria. It also includes, arboviral infections that also mimic malaria and tend to be treated as malaria in many of our countries. So yes, there is need to integrate vector management and look at how best this can be done. Of course, the other interventions, I'm not an expert in vector control. I'm just a generalist in that. But environmental management practices, we as malaria people engage more in level source management using of natural, biologic, or chemical products to control breeding in breeding sites. But in terms of the environment and the sectors that are engaged in making these environments sometimes suitable for mosquito breeding, how do we work with them to advise them to ensure that any of these issues are addressed to ensure that we do not have mosquito breeding sites? We also need to speak to that. And that's why when we talk of the global vector control strategy, it talks about a huge multi-sectoral engagement for mosquito control and looking at wider aspects beyond just the indoor, the LLINs and the in-driving transmission. How do we know that they are, even though there is a preponderance of outdoor biting, outdoor resting mosquitoes, how do we know that they are the ones driving the transmission more than the indoor biting ones? This is interventions. I think you as the experts will also let communities and use of technologies can be used to actually identify, find these breeding sites and treat them, either by modifying the environment to eliminate the breeding site, what works best where, by distribute the vector control interventions, integrating them to achieve the best possible impact desired. Thank you.
Yeah, thank you, Elizabeth.
And I'll just add that the two are so closely related, and Elizabeth's exactly right. You need both. In a situation where you basically need enough diagnosis and is infected, and to create the opportunity for them to, in a situation where you've got very effective vector control, either because you have effective indoor vector control and most of your transmission is, there's a lot of transmission occurring outside. If your other strategies are effective at reducing malaria transmission, they could reduce the need for additional doses of treatment in the case management side of things. I think we have suffered a little bit from the specificity of our technology, which is well suited. Indoor house spraying and insecticide treated nets really well suited for Anopheles gambiae sensu strictu, which has adapted alongside human populations to preferentially feed on people and to bite and rest indoors. But sometimes with effective use of IRS and ITNs, we can totally reduce that population so far that we can't even detect it in our entomological surveillance. And we expect that other mosquitoes are still responsible for most of the transmission. But I think Fredros has made me sensitive to the fact that even if we're not seeing Anopheles gambiae sensu strictu, it's such an efficient vector that its presence in very tiny and sub-detectable numbers
is important for us making decisions, so we are not over-specialized to the level that that we start to do wrong. I mean, I just want to express that and also just to explain a little bit why it's important for us to have some of these master classes that are delivered by people who are not vector control, even though the core has traditionally been vector control. So it's really nice to just hear what your perspectives on this subject are. Sheila, back to you.
Sorry, Fred. I think that was it on me from a list of specific topics, so we can move forward to the next one.
Okay, thanks a lot. Let's move this forward. We're gonna try and skip that, and actually I'll return this to Sheila. We want to discuss a little bit about coronavirus, both the positive and the negative.
Everything was up and what needed to be done. And as we can see, particularly in the beginning last year, even in countries where we have admired, the robust health systems, we saw that this could get easily overwhelmed. And one of the things was, then what happens in our places where we are always just, operating on the edge? What would happen? And I think at the beginning, at the outset, one of the every focus on health was like everything stops and we address this COVID monster that we are now faced with. But I think I think malaria was also one of the programs that, wait a minute, we also have to ensure that even as we address COVID, we do not lose sight of a lot of the gains that have been made in health, especially for a short time. You get this reversal of the gains made in child health, immunization, malaria, and many other diseases that we could think of. And the malaria team did put out a document encouraging ministries of health, malaria programs to put in place systems to ensure continuity of some form of service delivery and guidance on how to modify delivery of certain interventions, taking into consideration the requirements for infection prevention and control necessitated by the COVID pandemic. So this was done and these were distributed, and there were, as many of you know, particularly in your country and maybe in other countries that you have worked in, how 2020 was a huge year for mass campaigns in sub-Saharan Africa, mass net distribution campaigns. A lot of IRS activities had to go back to the planning board, look for additional resources to provide personal protective equipment for delivery of these community interventions, protecting both the recipients and also the community and health workers who are going to deliver these services. On the part of case management and diagnosis and treatment, as we all know, we faced a demand side and a supply side issue. On the supply side, the health workers, a lot of them were, reassigned to now deal with COVID. We had, disruptions with closures where you can't open a health facility because there's cuts in transport, no movement, you can't get commodities in, so services can't be offered. And on the demand side, we had people who were just like, no, I'm not going to the health facility. I might get, meet this COVID thing that's going around. So we are just not going to seek care. And I think there were very good efforts within countries to address some of these issues, public health information, health worker information as well, trying to create routes for essential service delivery and for essential workers to get to work. But what I see particularly for malaria was the strength of community health systems where these existed to provide care. In countries like Rwanda, Mozambique, where there was already community case management for malaria and other diseases, these became the go-to point for people. They felt safer with the community health workers. And for a certain time, these community workers were the primary caregivers for malaria in those communities, with a lot of benefits that were received from this. So yes, COVID did have certain impacts on our disease control. Did it overall impact death and illness? We are still yet to see that. The data is out. From month to month data that we look at in countries that were sharing data, yes, there was a decline in facility attendance. Does that mean that there was no malaria? Possibly not. Were there challenges with reporting? Yes, maybe this has stabilized and we will be able to see the impact. But you know, one other thing we saw, maybe not now, but particularly in 2020, in the first wave, when the cases were very, very low, and even in the second wave, we still don't have, in most of our malaria endemic countries, very extremely high burdens of COVID-19. But these tend to be very urban, big city, where there are big airports, lots of movement, whereas the more rural areas tend to have very sporadic, you know, reports of cases. So you don't really see that this disease has impacted the other one or one has impacted the other negatively. And lastly, a good thing that happened, and many of the programs that are here can attest to it, is that fever was a hallmark for COVID, but fever is also a hallmark of malaria and other diseases like TB. So how do you know someone has COVID-19 or malaria or TB? And the guidance from WHO was that we should always suspect diseases that are endemic in our settings and not rush to conclude someone has COVID-19. Mm-hmm. And I saw that programs in our region, we have excellent examples from, high burden countries like Malawi, low burden countries like Eswatini, that said anyone presenting to a COVID treatment center or suspected to have COVID-19 should also have an RDT done for malaria to exclude this. Or prevent, you can die from malaria while people are just putting you on oxygen, thinking that, you just need to sort your COVID-19. So these were very good practices just to ensure that we do not miss malaria cases. It happened, I'm sure, in many other countries as well, but of course required additional diagnostics, the procurement of these and information of health workers that yes, the patient may be presenting with COVID-like symptoms, but have you ruled out malaria? Have you ruled out these other possible diseases? So I think this is what we'll see. But in terms of overall impact on actual disease on the continent, I think we will see that as all the data countries collect their data and analyze. And we may see a mixed picture overall. Some countries with reductions in malaria due to reduced movement, people not coming in, people not leaving. We may also see countries that report an increase in cases, and we may see countries where the normal curve was not affected. Thank you. Over.
Thank you,
Thank
Elizabeth.
Do you know if Dr. Noor is still on the line, if he wants to make any comments on this data to COVID? No? Back to you, Sheila. No, Patrick?
Oh, I think that was very well said. Thank you.
All right. Patrick, do you think that there will be any positive developments, specifically, I mean, anything that's coming on the vaccine side?
We have I think the COVID vaccine situation, I think it has maybe reset the bar for what the global community can expect is possible for the speed and efficiency of development of vaccines in the future. I think we are at a situation where we have one malaria vaccine that has a preliminary approval from the European Medical Authority and is in implementation project status in 3 African countries right now. And there's an expectation that maybe as early as this October, we'll have enough information to consider whether to deploy that vaccine more broadly. Like our other interventions that Pedro reminded us at the very start, it's not perfectly efficacious. Whereas the COVID vaccines approach 70, 80, 95% efficacy, our malaria vaccine, RTSS, is in the range of 30, 40, 50% efficacious in different settings. And so using it alongside the case management and vector control tools will continue to be a priority.
Thank you.
Thank you. And just to add, I love the language that the COVID-19 vaccine has allowed us to explain in terms of efficacy, because the malaria vaccine does not really prevent infection as such. And what it does is reduce the incidence of severe malaria in this very vulnerable age group. And the efficacy was measured on clinical episodes of malaria. And perhaps if we go back to looking at how many children, can be prevented from getting severe malaria and dying, maybe we will, upgrade that effectiveness quite a bit. And I'm excited that maybe we will, acquire some of this language, relook at that information and see how to position the malaria vaccine as a tool, as an additional preventive tool for malaria. So I like the language that we are using for the COVID-19 vaccine, and of course the opportunities it has given us for improving the current malaria vaccines that are available.
So you're saying that most of the
Fred, we can't hear you.
Hey, Sheila, you hear me?
Yeah. Yes, we can hear you now.
Can you hear me?
Yes, we can hear you, Fred.
All right, thank you guys. Sorry about that. I think my earphone just died. Elizabeth, you were saying that for the coronavirus vaccines, the question being asked is whether someone develops severe disease, whether that person dies. It's not whether they get infected. The question being asked on the malaria vaccine side is whether they get infected or not. So you were suggesting that if we were to evaluate the malaria vaccines on the basis of whether they prevent death or severe disease, we would be having a much greater efficacy or effectiveness.
Not quite exactly, yes, but you get my drift. The objective, the endpoints of the malaria vaccine are a bit different. And that's why even for the COVID vaccines, we are saying, what exactly were they measuring? Was it that you would never get COVID-19 or that you would not die if you got COVID-19? So they are saying, yes, our vaccine will prevent death in 95% of the cases. So I'm thinking, this is giving us opportunity to re-speak and re-advocate the malaria vaccine. It's not that I give you the vaccine, you'll never get malaria, your child will never get sick, blah, blah, blah. And also talking about the need to continue using your mask. Even if you get the vaccine, we should continue using nets. We should continue ensuring that we present. So I think the communication around this vaccine for me personally has given us an opportunity to reframe our communication and the benefits of the malaria vaccine as an additional tool in the fight against malaria, and not as the panacea that will come and solve all our problems for malaria.
Perhaps, Patrick, if you could add this, do you have any from your work with WHO and all that? Do you have any updates on? I remember in the early days during the malaria refresh, there were talks about new forms of RTSS, like the fractional doses of RTSS.
Mm-hmm.
Do we have any updates on that front?
I know that there are fractional dosing studies underway. There are studies underway to look at the potential impact of timing the COVID or the RTSS vaccine with
Right.
seasonal malaria chemoprevention in West Africa. And those data are, I think, likely to be shared later this year and contribute to decisions about potential wider use of the vaccine beyond these 3 implementation project sites.
Yeah.
So there's stuff in the pipeline, Pedros, and I'm told it's all very encouraging, but I think we want to be very sure too that the safety information comes through very solidly as well.
Yeah, I remember we had a class with Brian Greenwood, and I remember
Mm-hmm.
Professor Brian was alluding to potentially, encouraging news on that front as well. Thank you both, and I would like us to go back to Shayla, finish up with the vector control side as we draw towards the close. And I think we're gonna skip that and then just get to this. Yeah. Talk about future.
Yes, thank you. So we partially touched on this previously when we were talking about the balance between vector control interventions and case management, as well as when we were talking about stratification and the choice of intervention. So specifically looking at IRS, given the challenges that face the implementation of IRS with respect to acceptability by the community, we are reporting a lot of high refusals from some areas, some endemic countries. So generally, what do you think is the future of IRS given these challenges? Patrick, would you like to go first?
Yeah, I think we still have an important consideration for IRS in that it can use a wider range of insecticide classes than we currently can deploy on insecticide-treated mosquito nets. And so as a potential insecticide resistance mitigation tool, I think it can be very valuable. It is a challenging intervention to deliver, and it requires a high level of technical supervision and precision, and a high level of community awareness and participation. But when used properly, it can be effective at reducing malaria transmission from indoor biting and resting mosquitoes. And I think because of its potential to deploy additional insecticide classes, it can potentially really be an important tool in resistance management or mitigation.
I noticed that Professor Pedro has rejoined us. Pedro, welcome back.
Thank you. Sorry for the delay.
We had lots of questions about MDA that were targeted at you, but at the moment we are discussing shall I just ask our experts about the future? We have spoken to some experts before in recent masterclasses, and there is a school of thoughts that suggests that in the very near future, this intervention approach will not be desirable to most people. And part of this is just like, when people get better socioeconomic states, they are more likely to reject the idea that you want to spray their wall. Stuff like that. On the contrary, you can argue that, maybe they are also better protected against malaria, but there are also questions about costs. The data for IRS, when we look at it, it's kind of flat. It's not, the coverage is not rising at all, even though the number of countries accepting IRS is going up. So as a malaria control community, the question Shayla and I have here is whether we should be imagining a future already where indoor residual spraying will not be on the table. And that future will probably come before 2030, according to some experts. Very general thoughts on these ones. And Sheila, I'm wondering whether we should recall some of the questions on MDA now that Pedro is back, so that he can finalize with us as well.
Yes, let's hear more on his opinion about the future of IRS, and then we can go back to MDA.
Go ahead.
Okay, while Pedro is thinking, can I just say something about acceptance?
Yes.
I think it is important never to conclude that the reason for refusal of IRS is the same. Like LLIN acceptance and use, it is important to understand why the community refusal is there. What are their fears? What are the challenges they're facing? And see how those can be addressed. If we make assumptions and we do not address the reasons for the refusals, then yes, we may make a very impactful intervention not impactful, because its impact is really dependent on acceptance and a high level of implementation and quality implementation. So it's not, I mean, I have lived in a town and in a city. I have had my walls, with the best paint, but I have also had IRS done in a way that no one would ever know IRS was done. So it can't just be that people are, feeling that they don't want their walls damaged. Then why are their walls getting damaged by the spraying? What are we doing? Are these issues that we can address? So that is why community engagement and feedback and addressing those fears is a continual process, and is something as public health people we must continue to do. We should not always assume that everything we throw out there will always be accepted, but we must be willing to address the fears, the challenges, and reassure them, and also show them, and use influential people in the community to be, like the guys speaking for us and speaking with us to ensure that the uptake is optimal. Thank you. Over.
Agree with Elizabeth. Wouldn't add a single word to that.
Yeah. Sheila, if you don't mind, before we go back to the MDA questions, I just want to ask Pedro and Patrick a quick question about cost effectiveness here. Patrick and Pedro, this is specifically for you, and I probably won't be able to ask it in the perfect way, so you can help me ask the right question here. We are talking a lot, and it also was shown in the GTS document, we are talking a lot about optimizing the core interventions, ramping them up to the highest possible coverage. We are talking a lot about making sure that everybody has the best things that we have right now. Now, this publication is from 2003, Chris Murray at the time, still supporting WHO, and cost effectiveness is the question here, but more importantly, the incremental cost effectiveness ratio. Mm-hmm. The idea that in the beginning, as you increase coverage with these interventions, you are getting a lot of, a bang for the buck, if you like to say that. Mm-hmm. You're getting a lot of benefit from it. At a certain point, you start to be spending much more money, but getting very little additional benefit with that. And it means, therefore, that the gain you're getting from things such as, scaling up ITNs from, 20% to 50% will be much higher than scaling up ITNs from 50 to 80 and from 80 to 100. Yet the cost is probably higher or maybe the same. But when I see people have discussions about let's scale these things up, I rarely see this incremental cost effectiveness ratio being factored in. And I'm wondering whether at a certain point, we have to then decide that we are gaining too little for the amount of money we are spending, that perhaps maybe we should spend that money on something else instead of just always focusing on this, you know, universal coverage with every tool. How does this play into the current strategy? And because we don't, this morning, Shell and I had a long discussion about whether this is even a question worth asking. But clearly speaking, I mean, I spoke to Philip Welkoff 2 days ago, and he was talking to me about this, you know, the assumption that these relationships are linear. They are not. They're definitely not linear. What are your thoughts on this?
I'm going to have to leave in a little bit, so I'll take the liberty of speaking first. But I know Pedro has given this a lot of thought as well. I think one of the real advantages of the commodity-based approach that we embarked upon in 2000, 2001 was that commodities were viewed as scalable. If you had more money, you bought more commodities, right? And that works really well at the lower end of this incremental cost effectiveness curve. But as you get towards the higher end, it's not the cost of the commodity that drives the program to reach those last few people. It's the cost of reaching those people. They're harder to get to. They're in more remote places. They take more convincing to completely utilize the tools. So yes, there is a calculus we need to attend to that's more than just the incremental cost of additional commodities to reach 80, 90, 100% coverage. It really is at a certain point, where does it become a better use of our resources to invest in other interventions? So with that, I'll thank you so much. And please, I'll share my contacts if anyone wants to get in touch with me.
Thank you. Thank you so much, Patrick. Thank you.
So thanks, Patrick. And I agree with him. And again, little to add. I think this is one of the key challenges that we have ahead. And partly because I have a certain sense that we've operated in a slightly siloed way. So, and WHO has not given sufficiently good guidance or fostered sufficient thinking at the relative cost effectiveness at different coverage levels of different tools. And now with the concept of stratification and intervention mixes, this needs to be further brought into the equation. So personally, I think that this is a critical area of work, strongly linked with the concept of mixes of interventions and national and subnational stratification. And it's an area where we're working, but we're not there yet. But it's good that you raise this point because it is essential. What benefits do we accrue from increasing coverage of bed net, say, from 60 to 80%? Is that the best investment for those resources versus doing further chemoprevention approaches, or investing on the further scale of IPTP or other options? So I think this debate and this question is central to our strategies moving forward.
Thank you. Thanks a lot, Pedro. Back to you, Sheila.
I can't see the slide.
Do you want me to pull back the slide for the MDA?
Actually, no.
Okay.
I don't think I had any questions for Pedro.
Okay. All right. So I'll pull that up, and then we just can close with that question. Pedro, if you don't mind, we have Here we go. So, you have previously written that of the many tools we have, the one for which we're probably not maximizing the benefits at the moment is MDA. And we had a long discussion here while you were away. You were away about where are the opportunities that you see now to actually do that benefit maximization with regard to MDA for malaria control.
So
do we have real cases where we can get great benefit by implementing this, and in which form?
Yeah. No, thanks. I think this is an area I feel strongly about, and it stems from what we were discussing earlier this afternoon. We don't have great prevention tools. Vector control is good, but it's not brilliant. Even when we deploy highly efficacious insecticide-treated bed nets, at the time when there was very little or if any insecticide resistance, efficacy was whatever, 40, 50%. So we're not doing great in terms of disease prevention. And if you look at it, we have vector control, great, but with its limitations. We have environmental management, fine, but we don't have many other things. We don't have a vaccine yet, and I gather that you've been talking a little bit about vaccines. And the only other thing we have is antimalarial medicines. Now, when people from Europe or the US go either on holiday or for work in malaria endemic countries, what do? They take antimalarial medicines. So why don't we use, and they are very highly efficacious. They prevent more than 90, 95, 98%. So why, if we accept that antimalarial medicines are one of the most effective ways of preventing malaria, why are we not using it? And I think that there are a couple of issues here. One is that there's been remarkably little investment in developing antimalarial medicines for use as chemoprevention in general, and particularly in Africa. And I think that this has been a massive shortcoming of the R&D community, whereby the entire focus has been about using medicines for treatment of clinical cases. And so all the R&D effort has been case management or medicines for treatment, which is, of course, incredibly important, but it has left a blind spot, a forgotten space in drugs for prevention. So that's number one. Number two, it's been classically hampered by the sort of threat of resistance. Oh, if you use it for MDA or regularly, you're going to get resistance. Well, yeah, probably. Although we don't entirely understand that. We've been using SMC in West Africa now for 8 or 10 years, and there is no indication of increased resistance there. So we just need to be a little bit more humble as to our lack of understanding of the dynamics and population dynamics of appearance and spread of resistance. But fine, even if we accept that resistance would be developed, I think that it is the only other tool that we have at hand right now to massively impact on disease, severe disease, and death. And we're not using enough of that. IFACARA was heavily involved in development of IPTI, a modestly efficacious intervention, but using existing delivery platforms, which actually appears, according to the Imperial model, as the most cost-effective of all the malaria interventions in the entire malaria toolkit. It's not being implemented. IPTP, which reduces disease and death and neonatal mortality, at an incredibly low cost is one area where we should be ashamed as a malaria community. Only 30% of women are receiving at least 3 doses of IPTP. I'm surprised that we're not regularly on the front page of the New York Times for not preventing malaria in pregnant women in Africa. SMC has shown the potential of MDA. I mean, SMC is MDA, is an age-targeted MDA, which is the provision of an anti-malarial medicine to a population at risk independent of their infection status. And it has made a massive impact in West Africa. So MDA in different forms of MDA in Zambia brought malaria close to being eliminated in some parts of Zambia. In southern Mozambique, MDA together with other interventions reduced 2 rounds of MDA per year, reduced morbidity close to 80%. So why are we not using this more frequently and more aggressively? Personally, personally, if we have 400,000 deaths a year in Africa,
right,
we could massively reduce that if we adopted an uncompromising, bold approach to go to the areas which we don't reach and where mortality concentrates, and we agree to regularly MDA those areas. We would be saving hundreds of thousands of lives every year, but we're not doing so. And there's massive resistance from the community to adopting bold approaches. I can assure you, if this was in other more developed, I mean, as we're seeing with COVID-19 and so on, we would do whatever it would take to stop mortality, but we're not doing it.
So, just on that specific point, so two items. It appears from what you're saying that the goal would be different. The goal would be to stop deaths.
That is my number one priority. I mean, we've been driven for too long. The concept that it's all about reducing transmission. Well, of course, reducing transmission is important. And eventually has a knock-on effect on reducing disease and death. But there are other tools that may not necessarily impact transmission in a major way. But if they do reduce severe disease and death, I'm all for it. In fact, I think it's our number one. And with HPHI, we've tried to argue this. We have to assess our priorities. Mine, personally, my number one priority above anything else is reduce mortality.
Thank you.
Number one. I want to stop those 400,000 deaths. Then we can discuss about, can we do so at the same time on elimination, reducing transmission? Sure. I think we have to stop those deaths.
Do you think the focus on elimination is possibly a reason for the reluctance to go for MDA?
No, I don't think so. I think the reluctance is much more on old preconceptions around fostering insect drought resistance, about this not being sustainable. And frankly speaking, we haven't been terribly serious about this. If we accept that we do 4 rounds of MDA to children under 5 in a cohort of 30 million children in West Africa, that's SMC, and we're happy to pay for it, why? That is, to me, MDA. That is right. That's the right thing to do. Now, the question is, why do we restrict it to only areas in West Africa? Why don't we take that MDA approach and go to other areas and do basically something adapted to the issue? I think.
Do we have the right medication for the South of the Sahel?
No, we don't. No, we don't. But we are using what we have. Amodiaquin SP is not the brilliant, is not the ideal drug for MDA, or in this case for SMC. It requires 3 days treatment every month for 4 months or 5 months or 3 months or whatever. And it would be much better if we had a single dose MDA treatment. by the way, like SP. SP is a single dose stat treatment, which is exactly what we want. Unfortunately, it's not as efficacious as other medications, but we do have, and so we don't have the ideal medicines, but we can use, as the malaria community often does, we use what we have at hand. DHA piperequine, you have it there. Artesunate paranardine, amodiaquine SP. There are not optimal, but things we can use, and that could actually help us massively reduce mortality now.
Thank you so much for the clarification. You know, Elizabeth was talking earlier about how the language around coronavirus vaccines could help us here, because in that field, people are talking about reducing severity, reducing death. And that seems to work very well. Pedro, a related question to this is, a lot of countries no longer use SP for treatment, but we still have this for IPTP. Is there a question here about, you know, resistance still lingering, people wanting to have new medicines for IPTP?
So do I. I want fantastic medicines. I want stat treatment, stat doses that can be directly observed, given, and that provide 6 months protection. But we haven't got it.
Yeah.
What we have right now is SP, and SP clearly fails for the treatment of malaria, but we've also learned that failure for the treatment of malaria does not necessarily lead to failure as prevention of malaria. For all we know, SP continues to work pretty effectively in the prevention of malaria in pregnant women, and no other treatment, including those that are more efficacious for the treatment of malaria, like DHA piperequine that you have there, have proved to be superior to SP, even in areas with resistance, in improving, for example, birth outcomes.
Yeah.
So again, we have to be driven by data and not by assumptions. It has been very harmful to the malaria community to label SP as a failed drug. It may not be a useful drug for the treatment of malaria right now, but it is the best we have for the prevention of malaria in one of our key target groups, in this case, pregnant women. And they will label it a failed drug on the assumption that its failure, that not being sufficiently efficacious for the treatment would translate in lack of efficacy in the prevention, which of course they didn't know. And in fact, we now know that it doesn't correlate. So it's a self-inflicted damage by the malaria community. We're terribly good at doing that. And rather than saying we have something that works in one of our key target groups, one of our most vulnerable populations, primary gravids and second gravids, particularly in Africa, and the effects of malaria in pregnancy, in the pregnant women, in inducing prematurity, low birth weight, and thus neonatal and infant mortality, that has to be our focus. We have an imperfect tool, but we haven't got anything better. Let's use it. We should be achieving coverages of 80%, 90% in IPTP. We're down to 30%. It's bad, and it's self-inflicted by the malaria community. Lack of humbleness, assumptions not based on data. We have to go back to taking malaria as a problem to be solved. We have to ask ourselves, what is the problem we're trying to deal with in this community, in this district, in this province, in this country, and answer the questions based on data, and adapt our malaria control efforts based on knowledge, not on suppositions. And I think that the entire chemoprevention space is a great example Oh, we cannot use MDA because of drug resistance. Really? Can you show me the data? Can you really show me data that shows, and in fact, we can show data that it is not the case in West Africa. So far too many assumptions, far too little evidence, far too many hypothetical approaches, leading to often paralysis, and very unhelpful paralysis that translates into deaths, frankly speaking. It even reminds me of the time of bed nets. You remember in the 1990s when they said, oh, bed nets by reducing transmission are going to shift the age pattern of disease to the right and actually increase mortality. That led to paralysis for 5, 6, 8 years that translated into deaths. And that was just a hypothesis, not data driven.
I hear this, and thank you for for expressing this so passionately. I don't know about Sheila, but I think that the idea that even if we don't eliminate now, we can stop the deaths is an important one, and that we have tools to be able to stop the deaths. And you see this with other diseases. I think coronavirus is a fantastic example where, you know, even just stopping the deaths is a very big achievement. And why we are not doing that is a different question. Thank you very much, Pedro, for this. Thanks, Elizabeth. I think we're gonna wind towards the close now. We've been on this for nearly 3 hours. Thank you. I wish we had a lot longer. Fortunately, very interestingly, we still have 60% of the people who started with us are still with us. So it's a very, very long calls. Sheila, do you still have any pending questions that we need to ask Elizabeth and Pedro before we wind this?
Yeah, so I think the question that we like asking our speakers is about your career, the choice of the career you chose. I mean, the path you chose. What influenced the kind of career you have chosen? If you have chosen, like where you're working now, what has influenced you to get to where you are now? Have you had any mentors along the way? This is just so as to sort of let our young scientists learn from the career that you have chosen, learn from the choices that you have with regards to the career. So just briefly, very briefly, Professor Pedro and Elizabeth, just please talk to us briefly about this.
Elizabeth, do you want to go first?
Thank you, Sheila. Actually, I started my life out as a young research scientist, like many of colleagues here at Ifakara. After finishing medical school, I worked as a medical officer, and I didn't like the donkey hours. So when an opportunity came for a research clinician for, interestingly, PMTCT, prevention of mother-to-child transmission of HIV, and the cohort was interestingly of women who had also participated in IPTP. So I was in a malaria in pregnancy, prevention of mother-to-child transmission of HIV research study. And this continued as my research field. I got participated in, Pedro, you'd be interested to know, as a clinician in IPTI studies in Western Kenya. And and I think it just went on from there, got interested in, got roped into clinical trials, worked with the Ministry of Health, providing support for therapeutic efficacy studies, got dragged into the malaria program to head the program for a period of time, went back to research, and eventually joined WHO. So I think briefly that has been, I mean, I have worked with great people who've participated in a lot of these master classes, both directly as mentors and scientists. Of course, Pedro now as my boss. You know, along the line, very many. I think Pedro may not know this, but yes, when they were doing the IPTI summary studies, we would sit and listen to them talking eloquently, but then I was a little girl, so he may not have noticed that I existed. But he did have a great influence with the team that they were working on then. So I think for the research scientists, for the young people working at Ifakara, I have been at Ifakara myself, both as a student, but also as a what do you call it, facilitator? I don't want to say I was a tutor, but as a facilitator of some courses at Ifakara. But I've also collaborated with them on certain research on studies, clinical trials as well. So there's been a great relationship with both the Institute, with the young people. We've grown together. I have great friends there, Deus Ishengoma, and a lot of people who started out at KCMC in Kilimanjaro. And so that is the path. And just through doing this, it got me to where I am now, working at WHO as a medical officer on malaria, and also just supporting program implementation for countries. Thank you. Over.
Thanks, Elizabeth. Well, of course, I
Thank
did
you,
note you.
Elizabeth.
I'm not her boss, just to be clarify that. I'm her humble servant and colleague. No, in my case, I mean, I won't go through my entire CV, but it's boring. But just to say that that I've been very fortunate. I started working in the Gambia, and as a clinician, and then to move on to epidemiology, and got interested in malaria epidemiology, and then was very fortunate to be involved with my colleague and brother Steve Lindsay on the first trial that showed the mortality impact of insecticide-treated bed nets. At that time, we were actually dipping the bed nets ourselves. But that was a large study at the time when it was thought that insecticide-treated bed nets wouldn't really work. I've often mentioned this. My first meeting, I came to Geneva, must have been in late 1987 or early 98, in which the evidence of insecticide-treated bed nets were being reviewed. And there was a big dispute. And this was the times of Chris Curtis, and I saw Joe Lyons was on the call at one point, and Pierre Carneval and others, and the evidence was very, very messy. But the conclusion of that first meeting was insecticide-treated bed nets by themselves will never become a major public health tool for use in Africa. So they were dead. And with Brian Greenwood, my mentor, and Steve Lindsay, we decided to do what effectively implied what we call the double intervention study, was insecticide-treated bed nets plus minus seasonal malaria chemoprevention, which we then called it a different thing, but it was exactly the same thing, regular doses of an anti-malarial during the high transmission season. And one of the only probably clever things we ever did in my life was to ensure that there was a control group where we could actually compare insecticide-treated bed nets versus normal non-treated bed nets. And to our surprise, we found a very large impact on mortality, which we published in Lancet in '91, and that opened up the door for the 4 TDR-sponsored trials that confirmed the large impact on mortality and morbidity that bed nets had. So that was the Gambia, and fantastic years, and so much learning from Brian Greenwood, from many of the giants at the time there, and partners for many years later on, from Bob Snow to Kevin Marsh to many others, and of course my brother Lindsay. And then Ifakara was again a life-changing experience, and my brother Honorati Masanja, who came for interviews for a position we were trying to recruit, but we decided to recruit a very clever lady as a statistician, who happened then to be Masanja's wife. But we then ended up recruiting Masanja too, and a close friend and partner for many years, and so much I learned there. And there we did some of the first, in fact, probably the first set of malaria vaccine trials in Africa, which we learned so much and basically defined the clinical development path for a malaria vaccine, which is still being followed up now for other products. But also some of the work on chemoprevention in children under 1, and then leading on to the IPTI work that was first done in Ifakara, and some of the work on prevention of anemia. An amazingly productive time, but such a profound experience. And what I learned from all my colleagues there, from Hassan Mshinda to Honorati Masanja, Urasa, and so many other very, very dear friends who have profoundly impacted what I've done. And then I went on to Mozambique, where we started building on the experience from Ifakara, a research and development center there where I spent the better part of the following nearly 20 years. And again, a lot of work there on malaria vaccines and IPTPs and IPTIs and other diseases, not just malaria. And then at an odd point in time in my life, was asked by the previous Director General of WHO whether I would take over the malaria team, and something that I had never really thought of or contemplated. And I came to WHO, and again, this has been an amazing time. I've now been here 6.5 years. I've learned amazingly. I've tried to, in the best of my knowledge, try to help and advance the fight against malaria, building on an amazing group of colleagues here at WHO, and not just in Geneva, but in Afro, in Embro, in all the regions. And I just feel a very fortunate man. And my only advice to other colleagues is be bold, be daring, be passionate. This is a fantastic field where we can and we need to achieve so much, because there's a massive unmet public health need that needs to be tackled. So very fortunate and so grateful to life and to all the colleagues I have met and continue to meet, and such warm memories and gratitude to Ifakara and all my Tanzanian colleagues. So in a nutshell, that's a bit of the story.
Thank you, guys. Thank you so much. Thanks a lot, Pedro, and thanks a lot, Elizabeth. You might think that you are benefiting most from this ecosystem, but I actually think that we have benefited the most from the ecosystem. The masterclass session has been very, very educational for myself, and I believe for Shayla and for our other colleagues. And we would have wished to continue the conversation, but of course, time limitations and all that, we cannot do that. I think a lot of things that come up that we didn't even think about, the points about how do we communicate better, the point about separating the question of elimination from the question of deaths, you just want to stop this. There's some of the earlier points made about subnational stratification. Shayla was very keen from her work with the CHAI to look at case management and how this interplays with vector control in different settings. And I think a lot of those things have come together very well in this masterclass. I just would like to say a big thank you for that. We discussed a lot also while you were away, Pedro, about the situation in Zanzibar and how we can use that as an example. Some of the points that we have not discussed in greater detail include the questions such as incremental cost benefit, which I hope that we can discuss more in a different forum. At that point, I just want to say thank you again, and I want to hand back over to Sheila and for the final words on this.
Thank you, Fred. So a big thank you to our speakers today. We were honored. Thank you very much, Professor Pedro, Dr. Elizabeth, Abdisalan, and Patrick. Thank you so much for sharing your knowledge so generously. I'm sure we have learned a lot. I specifically take away one message is that we shouldn't assume. We should always ensure that for any decisions with regards to interventions and case management, we should always ensure that we are using data to inform these decisions. And one last one that I really liked from Pedro just now was about being daring and being determined and being bold. So with that, thank you so much all for joining. Thank you so much for the participants who stayed all the way to the end. Yeah, and welcome to the next masterclass.
Yeah, I just want to make a quick announcement that our next class, next week we will have no class. Our next class is on the 22nd, I believe, 21st of April. We will send out an announcement it's going to be vector control. We're going to be focusing on some lessons from Aedes aegypti control and how we can implement those for malaria control as well. We will share that information back to you again. Pedro, I know you're very busy. Elizabeth, we know you're very busy. Thank you again, and we see you next
thank you. Thank you so much. Sorry, I had to, so just count me in any other time. I'll be very happy. I think it's so important what you guys are doing, and that this is run and organized from Africa, and I was seeing the audience that you have. I think this is fantastic. Count me in whenever you think I can be useful.
Thank you so much for your support.
Thank you. Brilliant.
And thanks,
Bye.
Elizabeth. Thank you so much. Thanks, everybody. Those who are still on the call, if you need us to have any communication to you, just send a message to us, and we will send you, if you want, for example, the slides and so on.
Pedro, please share the recorded clips.
We will. Hi, Deus. It's nice to see you there.
Bye. Thank you.
Thank
Bravo.
you so much. Yes, sometimes. Sheila, I'm calling you shortly.
Okay.
I'm just going to close this here.